This is a real personal talk, so if at any point you have questions or want to raise your hand and take time to kind of dig into a slide, that's fine. Otherwise, we'll stop at the end to take dedicated questions too. So we'll be talking about knee pain. As she said earlier, here's a little bit about my training history. So I grew up in Macon. I went to the University of Georgia for undergrad, followed by the Medical College of Georgia in Augusta. And then I left the Georgia Public School route and went to Chattanooga, Tennessee for my orthopedic residency for 5 years. And then we decided to move back here to Moultrie to practice. This is where my wife's from, and I kind of knew I wanted to be small town Georgia practice for the whole career, even before Ann and I started dating seriously, but that just checked that box once we made the decision. So it's been good so far. So today we have several topics. One is probably the most interesting crux of it, which is the surgical treatment options. We'll talk about knee pain, specifically different types of arthritis, and how those things develop and affect your daily life. We'll talk about some conservative treatment options that we typically dive into before the surgical discussion is begun. And then we'll talk about what knee replacement means and what the Mako surgical robot brings to that equation, what it is, how it's done, and what we'll talk about if, in fact, that's something that you're interested in. We'll also talk about the experience of having a knee replacement from the day of surgery to your discharge home from the hospital, and then we'll talk about your recovery expectations, and we'll follow that up with some questions at the end. So as some of you who are experiencing knee pain may know, it can be extremely debilitating. We don't realize how much you utilize your knees, ankles, and feet until they hurt every single step. So it's really important to jump on this early because although it's not an emergency, it's progressive. What I commonly say in the clinic is you're born with an amount of tread on the tires, and that tread gradually wears out over time. It doesn't happen in one particular incident, but it will continue to progress. So getting in and discussing both conservative and surgical options is important. Three main types of arthritis, the most common being the middle, which is osteoarthritis. That's basically just wear and tear arthritis associated with things like activity, genetics, and some other factors. The top is rheumatoid arthritis, or if you bundle that into a broader category, that would be something called inflammatory arthritis, which is sort of like an autoinflammatory condition where your immune cells target the synovial tissue around the joint, causing breakdown, resulting in a similar problem, which is continued pain of the joints. The last is a little bit less common, but can be fairly debilitating, which is post-traumatic arthritis. What that means is you've had a joint injury or fracture that leads to uneven surfaces in the cartilage, which obviously results in early wear and tear and degeneration of the articular surfaces. So those are the three, not all-inclusive, but most common reasons why we see people for knee pain. So what are the non-surgical options? People usually come in and they're worried or interested in or have heard a little bit about knee replacement surgery. Knee replacement is the gold standard for end-stage arthritis, but it is also the last option. It's the thing that we discuss after you've exhausted all else. And the reason is because you're making a decision to undergo something that has risk. So we're constantly balancing risk and benefit, and when you get to the point where your quality of life has been extremely limited by your symptoms and you no longer respond to conservative management, then the discussion for surgery is warranted. And those options are as follows. Walking aids, that's pretty rudimentary, but is useful early on. Heat or cold therapy, I particularly recommend cold therapy often at night especially, because these symptoms can wax and wane, and even if you have a chronic problem, you can have an episode of hyperinflammation where you'll swell and hurt, and the ice at night can help for your symptoms the following day. Physical therapy can help if you have a little bit of malalignment or muscular imbalance. It can help strengthen you and help you tolerate the symptoms that you're having. Oral anti-inflammatories are a mainstay, so we write that just about every time I see somebody the first time for knee pain. I'll adjust their anti-inflammatory regimen as long as your medical problems allow you to take that. So when is the discussion move from conservative management to a discussion about surgery? So we've exhausted the conservative options that we just talked about, and we're ready to talk about the next step. And typically, I ask about certain things. Is it affecting the things that you used to like to do and you're now no longer doing those things because of your pain? Does it wake you up at night? Are you less active? Does it affect your ability to navigate hills and stairs? So walking up and down stairs, do you feel unstable and progressively unsafe because of your knee pain? I think when you're starting to check those boxes, it makes sense for us to start digging into whether or not you think this fits for the next step in your treatment. So what does that mean? A lot of people have heard what a knee replacement means, but there's a lot of misconceptions, so we'll dig into that just a little bit. So on the left side of the screen, you can see basically a bony and ligamentous breakdown of what your knee actually looks like. So at the top of the screen is the femur bone or thigh bone. Bottom of the screen is the tibia bone or shin bone. Those are the two main articulating bones of your knee joint. In the front is your kneecap, and the kneecap forms the third compartment. So you have the medial compartment or the inside, lateral compartment or the outside, and then what's called the patellofemoral compartment. All three can become arthritic, and as you can see on the left side of the screen, the redness is indicative of cartilage that is worn down and exposed bone. Those bones have nerve endings, and so when the bone grinds and catches, that becomes painful. It's achy and throbbing and difficult to deal with. So in your mind's eye, that's a little bit of what's going on. As you can see, that's what I just said. So here are some radiographic or x-ray representations of that same previous image. So on the left side of the screen is a healthy knee. What I like to point out is that you can basically extrapolate the status of the cartilage by the absence of bone. So bone shows up on x-ray, and the top of the screen is the femur bone, like we said. Bottom is the tibia bone. When you look at the two compartments, there are healthy spaces there. That tells you that the cartilage is still intact. There's reasonable tread on the tires. When you look over at your right side of the screen, the outside compartment, which is here, still has a little bit of joint space. It's a little bit hard to see on these images, but the inside, the space has essentially been eliminated. And the conclusion you can draw from that is that the cartilage has been worn down. And another factor that you look at is how white and what we call sclerotic the image looks on the inside, and that's because the bone is reacting to that increased contact pressure, and that's what's causing the pain. It's also important to note, we'll typically delve into the weight portion of how this affects your knee pain. It's important to keep in mind that 4 to 7 times your body weight goes through your knee and hip and ankle as you walk, especially up and down stairs. So any sort of change you can make on your physiologic status and your weight management will help you or hurt you, depending on which direction you move in. Here are some examples of both a partial knee replacement and a total knee replacement. If you have questions about the two at the end, we can dig into that a little bit. Essentially what the procedure does is it allows us to remove the degenerated tissue. So you remove the unhealthy cartilage and bone from the knee and replace it with metal and plastic parts of different types. Typically, it's a combination of a surface called cobalt chromium, which is very hard, wear resistant, and smooth, and a medical grade plastic, which acts as the bearing, as you can see by the white plastic in between the two bits of metal, and then a titanium tray on the tibial component. And those are typically the three things that contribute to a replacement for the knee. On the left side of your screen is a partial. Basically, if you visualize the previous x-ray we talked about that had medial compartment arthritis, in certain instances, a partial knee replacement can allow you to address the isolated compartment that's affected while allowing you to keep your anatomy in the other compartments. Here's another example of the partial knee replacements. We won't delve into this too much, but you have 3 compartments, the medial and lateral and patellofemoral. It is possible to replace each of those individually. However, it's a fairly narrow indication for that, so typically total knee replacement is the gross majority. Here are some radiographic examples of what we just talked about. Basically, the really bright area on the x-rays is represented by the metal. So you can see it looks quite a bit different than the bone anatomy around it. You can't see the plastic similar to cartilage, and that's because it just is not radio opaque, but it is there. So now kind of the meat of the talk, how we perform total knee replacement here now. Traditionally, we were able to put implants in the appropriate position and perform total knee replacement very well, just utilizing jigs and guides that you trained on to learn how to do the procedure. Now we've kind of tried to progress the way we perform the surgery. So what we do now is you gather a preoperative CT scan. The CT scan gives us complete assessment of your 3D bony anatomy, and then that's uploaded into the software that's provided with the Mako. During the surgery, we then do a series of checkpoints to confirm that your preoperative plan is consistent with what is actually going on dynamically in real time. And then once you make the decision about sizing, positioning, and location of the implants, the robotic arm helps you perform that nearly perfectly. So that's the workflow, and we'll kind of let a video explain that a little bit better. It seems like it's very new, and it is new to the Southeast. There is a Mako in Macon. They just implemented one recently in Tallahassee. They have one over in Savannah, and I think are considering getting one in Columbus. But other than that, we fill a large geographic area for robotics. However, it's been around for 15 years or so. They've done hundreds of thousands of cases with very good outcomes. So it's definitely an evidence-backed technology, but it's nice that we're able to implement that here in this smaller market. So here we go. How does it work?
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of x-rays taken at different angles that can help surgeons see things that they can't typically see with an x-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
So as I previously said, we used the CT scan to basically perform a large amount of the mental gymnastics that was traditionally utilized during the surgery in order to expedite what takes place in the surgery. And all you're doing is reaffirming the preoperative plan as you move throughout the case. So what does that mean? What does it mean for you? You come, have surgery, and do you go home the same day, you go home the day after, you stay a week? In the past, we stayed in the hospital for quite an amount of time associated with total knee replacement. In our hospital system, you will stay one night in the hospital. You'll be seen by physical therapy the day of surgery and walk ideally within 30 minutes to an hour after you get out of the operating room. So you're immediately allowed to bear weight. And you'll be sore. There's a little bit of postoperative discomfort. However, you do know that the pain you had preoperatively is now gone, and the pain that you're experiencing now is most likely post-surgical discomfort that will resolve over time. We immediately start physical therapy upon discharge from the hospital, and you'll see me back at the 2-week mark, followed by the 6-week mark, followed by the 12-week mark, and then stretch it out to 6 months after that. So it's regular checks to make sure you're meeting your ambulatory criteria and your range of motion. The goal in surgery is for me to not leave the operating room until your knee is completely straight and then flexes to 100% of what it did prior to the development of your arthritis. So you and I both know that we can get there. It just takes a little bit of a battle. And what I commonly tell people is we're going to be friends up until the time we have surgery, and then it'll take till 6 weeks until we're friends again. But after that, you'll be happy that you did it, but it is a little bit of a battle in the early postoperative period. What can you do afterwards? So Traditionally, we had quite a bit of worry associated with the wear of the implants. And the reason is because it's non-regenerative. It's metal and plastic parts, and it has a lifespan. But in my opinion, and a lot of current thought associated with knee replacement is you're doing this in order to get back to the things you love. So I say do the things you love. And you understand that there are cyclic load life spans on these implants, but if we have to deal with problems associated with that, then we can. I'd rather you experience prime quality life years early versus with hope that you may get another year to 6 months out of the implant. I say enjoy the life years now while you can, and we'll deal with the problems down the road if they arise, and they may not. All right, so that's my spiel. We got time, so are there any questions?
Right, where is the actual incision on the knee? Is it on the top or the side of the knee?
It's on the front of the knee, so it's called a medial parapatellar incision. It's almost in the midline, just offset to the inside of midline. And it goes probably about 4 centimeters above the kneecap and probably about 4 to 5 centimeters below the kneecap.
So it's essentially the same as if you had a knee replacement by some other physician and not using a robot?
Yes,
That
ma'am.
incision is
Yes,
still
ma'am.
the same.
So the length of the incision is the same. The difference, so I definitely wouldn't say it's minimally invasive. It's definitely not a minimally invasive procedure. It is an invasive procedure. But some of the benefits that the robot presents is that you can limit the soft tissue dissection required to balance the knee. So because the bony cuts are pre-planned and can be manipulated dynamically in the surgery, I don't have to do as much soft tissue stripping, so that can help with postoperative recovery. There's also, without diving into the technical weeds, traditionally you had to ream the femur bone, and some people reamed the tibia bone to guide where your cuts are. We don't have to do that anymore, so it's quite a bit less bleeding intraoperatively and bleeding after surgery. So those are benefits, but it's definitely not minimally invasive. Questions?
Obviously, the bone is cut, but going in there, are any muscles or tendons cut in that process?
So muscles and tendons are not cut, but the tissue that compromises the capsule of the joint is cut. And then you do remove some of the ligaments out of the inside of the knee. You have your ACL and your PCL in the middle of the knee. You don't need your ACL anymore after this surgery, but you leave the PCL because it's still functional in the setting of a knee replacement. And the reason is because the ACL prevents anterior translation of the tibia. It's a check rein to anterior translation, and the implant itself provides that translational restraint.
So your rehab is essentially the same if you have the robotic or if you have the...
Yes, ma'am. The rehab protocols are the same. We are seeing a little bit earlier motion, which is good. Traditionally, the goal was to achieve 90 degrees of motion by 6 weeks, and we're seeing well above 90 degrees at the first 2-week postoperative visit, so I've seen good motion early. But I would not say that anything is definitively different than traditional knee replacement. Any more questions? All right, thanks. Well, thanks for coming.